Good evening, everyone, and welcome and thank you for attending our Ahead of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. My name is Tanya Behel, and I'm a project manager for the Cancer Institute. Tonight, we are excited to welcome Dr. David Bartlett, Dr. Howard Edington, and Dr. John Lister. They will be speaking about transformative cancer therapy and the opening of the new Melanoma and Skin Cancer Center and Research Laboratory at West Penn Hospital. There are a few housekeeping items that we want to review before we start. During the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Participants are not able to speak during the conference, but again, we encourage feedback via the chat option. First on the agenda, we have Dr. Lister. Dr. John Lister is the Chief of the Division of Hematology and Cellular Therapy of the Allegheny Health Network Cancer Institute. He is an experienced transplant physician who participated in his first bone marrow transplant in 1979. Since that time, he has been involved in over 1,400 transplants. Dr. Lister received his initial exposure to marrow transplantation as a fellow at McGill University in Montreal, and subsequently further training at the Fred Hutchinson Cancer Research Center in Seattle. Thereafter, as a Terry Fox Fellow of the National Cancer Institute of Canada, he received additional laboratory training in marrow transplantation and immunology at the Ontario Cancer Institute, Princess Margaret Hospital at the University of Toronto. He returned to McGill and actively participated in marrow transplantation for the next 5 years before accepting a position in the Division of Hematology and Bone Marrow Transplantation of the University of Pittsburgh. In 1997, he joined the faculty at the Western Pennsylvania Hospital and has remained on staff as a transplant physician, clinical researcher, and laboratory investigator. Dr. Lister is professor of medicine at the Drexel University College of Medicine and has served on numerous scientific and administrative committees. Welcome, Dr. Lister.
So first of all, on behalf of all the members of the division, we would just like to say thank you. The division members express their sincerest gratitude for the generous support offered by the foundation. This is a defining moment in our commitment to research in service of our patients, and we look forward to great things happening in the future. So to give you an overview of our part of this, I'm going to speak from the standpoint of the Division of Hematology and Cellular Therapy and describe some of our point of care CAR T cell manufacturing. Also touch upon a work from malignant pleural effusions to derive tumor-infiltrating lymphocytes as therapy, and the new laboratory that will be set up that we will use to monitor the immune effects of these cellular therapeutic products, and also to generate correlative science that can be used to advance the field. So the Division of Hematology and Cellular Therapy encompasses 11 individuals, 7 of which are listed, or how many? 2, 4, 6, 8. 8 of which are listed here. Yazin Samhuri, a young faculty member, is a member of the lymphoma team and our lead investigator for clinical trials of tumor-infiltrating lymphocytes. This is an active program that he is spearheading at this time. Cyrus Khan is our lymphoma lead. I am on the lymphoma team and direct our CAR T cell manufacturing efforts. Albert D. Donnenberg, who joined us just recently, is instrumental in TIL manufacturing, will conduct all of the studies related to correlative science that will be performed. Santosh Sadashiv and Prerna Mevavala constitute our plasma cell dyscrasia team, which encompasses disease such as multiple myeloma. And Salman Fazal and Anna Kogut are our myeloid malignancy team. Salman is also the director of our hematopoietic stem cell transplantation program. You can read that as bone marrow transplant, and is our myeloid malignancy lead. So those are the team members that will be involved in the research that will be performed, thanks to the generous donation to create this laboratory. With respect to point of care CAR T cell manufacturing, I submitted a study, which is a feasibility study of manufacturing chimeric antigen receptor CAR T cells for treatment of patients with B-cell lymphoma and B lymphoblastic leukemia. This trial passed our IRB, has a NCT number, so it's registered with the government. It's done under an investigational new drug application from the FDA, and thus far we've treated 4 patients. 3 of those patients are still living. Unfortunately, our first patient just passed away last week. And all of the early stopping rules that were in the protocol were met. We were able to successfully generate CAR T cells and administer them to the patients without any unseen toxicity. And this has been reported to the IRB, and we are looking forward to continuing with further accrual to 10 and ultimately 30 patients on this trial. What we're planning to do with this point of care CAR T cell manufacturing is bring up a phase 1 trial, which combines not only our anti-CD19, which is the canonical form of these CAR T cells, but also an anti-CD22 CAR T cell product, which is also CD22 is also found on B cells, and we will be using this for treatment of primary CNS lymphoma. The principal investigator on this trial will be Yazan Samhouri. And this is a very novel form of therapy that has only been piloted in 2 or 3 places around the world. So we hope to bring this up in the coming year. A phase 1 trial of tumor-infiltrating lymphocyte point-of-care manufacturing for the treatment of malignant pleural effusion has been brought to IND application status. The PI in this is Dr. Bartlett, and Dr. Donnenberg is the laboratory lead in the manufacturing of these cells. So we look forward to being able to treat patients with this rather novel form of therapy. And we hope that this leads to information that allows us to further hone the ability of TIL therapy to be effective not only in the pleural space, but also in the abdominal cavity. We've done some preliminary work with an anti-CD30 CAR T cell construct that would allow us to treat Hodgkin lymphoma and CD30 positive T cell malignancy. Much more validation work needs to be done in the laboratory before this can be brought to clinical application, but we remain hopeful that will happen. Of course, we have other thoughts on the table, but this palette of things to do will keep us occupied certainly for the coming year. So moving on to immune monitoring and correlative sciences, we will use this laboratory to perform testing on manufactured products for their release for administration to patients. This has to be performed according to FDA regulations and good manufacturing practice. We have the devices and we have the expertise to do this, and have done so in our CAR T cell manufacturing protocol that will be applicable across the whole realm of immune effector cell therapy. Also, we will be able to use this laboratory to monitor the effect of the product upon the patient and their malignancy, and to provide insight into the biology of cellular therapy, perhaps generating new findings and new avenues to pursue therapeutically. These are just 3 pictures of machines in the laboratory that I'm sure Dr. Donnenberg will describe to you in more detail. The one on the left, it measures various substances in the blood which are heightened during the times that immune effector cells are doing their work. The device in the middle is a very sophisticated imaging system so that we can watch live cells do their killing. So in conclusion, we are seeing a paradigm shift in the treatment of cancer. And I think this will replace conventional chemotherapy. We will be using more biologics in different combinations, including immune effector cell therapy, to treat patients with these diseases and perhaps offer more of a cure and also providing treatments that are much better tolerated. It may be that we are not able to cure all of these diseases, but functional cure might be on the horizon for many of these diseases. So the way forward is clear. It is rigorous clinical investigation and laboratory research to better exploit the vulnerabilities that we have not yet discovered existing in blood cancers.
Thank you so much, Dr. Lister, for your presentation. Next up, we have Dr. Bartlett. Dr. David L. Bartlett is chair of the AHN Cancer Institute. An internationally recognized cancer surgeon, he is a pioneer in abdominal cancer treatment and a dedicated prolific researcher. He is also past president of the Society of Surgical Oncology. He served as a senior investigator in the surgery division of the Center for Cancer Research at the National Cancer Institute, where he developed innovative surgical techniques to treat patients with abdominal and liver cancers and performed cutting-edge laboratory research in viral-based immune therapies. Dr. Bartlett received his medical degree from the University of Texas Medical School at Houston and completed his surgical residency at the Hospital of the University of Pennsylvania in Philadelphia, Pennsylvania. He continued his training with a fellowship in surgical oncology at Memorial Sloan Kettering Cancer Center in New York City. He completed research fellowships at MD Anderson Hospital in Houston, Texas, and the Hospital of the University of Pennsylvania. Board certified by the American Board of Surgeons, Dr. Bartlett holds membership in several professional surgical and oncology societies. He received many academic honors during his career and has been chosen as one of Pittsburgh's best doctors every year since 2006. He has published over 370 research papers in medical journals and has contributed chapters to more than 40 publications. In addition, he lectures widely at national and international meetings and conferences. Welcome, Dr. Bartlett.
Thank you. Thank you. It's a pleasure to be here. And what I thought I would do tonight is just present kind of an overview of the exciting things that we're looking at in terms of cancer care these days. And there is quite a bit to share. You've heard already from Dr. Lister about cell therapy. And cell therapy is one of the most exciting advances in cancer therapy. And we're proud to have that as a significant program here where we have become a destination for cell therapy clinical trials from an industry perspective and have treated a number of patients with these innovative treatments, as you've heard from Dr. Lister. But I'm going to kind of give you the overview of where we are, I think, in cancer care today and what's exciting us for the future. So this is entitled Head of Cancer and Meeting the Challenge at AHN. And just as an aside, this is the Cancer Institute at Allegheny General Hospital, which we're very proud of. It was designed with patient-centered care in mind and is really a nice venue for patients who are undergoing treatments for cancer. So a couple of things. One is the good news here, which is that overall, the incidence of cancer, which peaked in the 80s and 90s, is on its way down. So that's good news for us. And cancer-related mortality is also down. You can see the orange line there for all patients, and then male and female in the blue and pink. So overall, the incidence of cancer is dropping and the mortality of cancer is dropping. And why is that? Well, a lot of it has to do with these two things. Society stopped smoking in the United States, and we got a lot better with cancer screening. And that cancer screening, as you all know, ranges from colonoscopies to mammograms, low-dose CTs for lung cancers, cervical pap smears, and other ways that we screen for cancers, PSAs and prostate exams. So all of that combined, but smoking cessation included, has decreased the mortality associated with cancer and the incidence of cancer. But there's still bad news. And bad news, as an example here, is pancreas cancer, where we have seen over the last 20 years, the incidence continue to rise. And although the death rate hasn't risen at the same rate, the death rate does continue to rise as well. So you see in the blue diamonds there, the incidence of pancreas cancer over the last 20 years, and that's gone up, and the death rate has gone up steadily. Now, there is a gap. It used to be that if you were diagnosed with pancreas cancer, you died of pancreas cancer. There is a gap now where patients are being treated and having good treatment responses, and some even cured, so that there is a gap between the incidence of pancreas cancer and the mortality of pancreas cancer. But nevertheless, going in the wrong direction. So we're not perfect yet, unfortunately, and still have a lot of work to do, but we've come a long way. And so a few things, I don't have enough time I could spend an hour on any one of these things, but I'm going to start with screening and where the future lies, because if you think about what we do, we've said that has impacted the incidence and survival from cancer, or probably more the survival than the incidence, is good cancer screening. But if you think about it, we're still very crude in the way we screen for cancers. So, you know, a colonoscopy, which we're asking everybody to do after the age of 40, is not easy, right? You have to come in, you have to have a bowel prep, you have to go under anesthesia, and you have to spend the day basically recovering from a procedure just to get screened to see whether you have cancer or not. It's very effective in terms of screening, but not easy, right? And we could talk about mammography and CT scans for lung cancer and all of these things under the same context. They're great screening tools, but not easy. And so the future to me is a personalized blood test for cancer. And this would be screening cancer using a blood test. That is easy. That is something we could get everybody to do. And if we can accomplish this, this would be transformational in terms of decreasing the mortality associated with cancer, because we would find cancers earlier, we would manage them, treat them, excise them, and have a much better outcome from cancer. And just to show you, tumors we know release into the circulation all kinds of things: proteins, DNA, RNA, exosomes, little membrane covered particles, a lot of things that tumors are continuously releasing into the bloodstream. And we have developed more and better techniques to identify these things in a very sensitive way. So we can use a blood test then to screen for cancer, detect residual disease after surgery, and to determine early on whether a patient's responding to chemotherapy or not. So the future, we're not quite there yet, but the future is a blood test for cancer. And this just shows you a lot of noise, but a lot of different things that we can measure. You know, we can measure cancer cells in the blood. We can measure proteins, literally thousands of proteins in the blood, other small chemical products from cancer cells, enzymes, DNA, RNA. We can look at the receptors associated with T cells, immune cells that are in the blood. We can look at so many things. I won't go into all of them, but as you can imagine, we can look at all of this in the blood. So any perturbation related to that cancer, we can identify some relative to that in the blood. And then using machine learning and artificial intelligence, putting it all together, we can create a fingerprint for cancer. And this is obviously very much a research tool right now, but there are companies that have already released blood tests for cancer, and it's in its infancy at this point, so that they're not as sensitive as we would like. They're not picking up all cancers. They're not picking them up at a small enough level. But we're going to see that continue to expand and continue to get better. There are hundreds of companies and researchers that are looking at different ways to identify these different things that we can measure in the blood to ultimately come up with that blood test for cancer. And this is what we're doing at AHN. We have a protocol. So if you're a patient coming in to any of our cancer centers across Western Pennsylvania, you will be offered to participate in this clinical trial where we will draw your blood and draw it every month during the first year of your journey with cancer, and then every 3 months thereafter, so that we get a serial display of what's going on in your blood during that time frame. And then we have ways that we can analyze that blood. We're using very sensitive PCR techniques, droplet digital PCR. We're looking at whole genome sequencing of the DNA. We have a proteomics lab that will do what we call discovery proteomics, looking at literally thousands of proteins that are in the blood. And because we have serial assays, we can say, well, what happened before you were operated on? And what does your blood look like after you were operated on? And then using that machine learning, begin to identify patterns that will predict whether there's cancer there or not. And that's going to be the holy grail. And not only, we're not the only ones doing this. We're working with over a dozen companies with technologies to help us in this discovery platform. But as you might imagine, these companies are also working to do this. So I'm just telling you that the future here is bright. At some point here, we're going to have a blood test that will be able to screen for cancer. So we're excited about that. And then there's managing advanced disease. What happens when the cat's out of the bag? And this is not a very pleasant looking cat, because that's the way cancer is when it spreads. So we're also focused on and have made a lot of advances, and will continue to make advances on managing the advanced cancer situation. And this, not that we want a whole lesson in cancer biology, but people ask, well, do we know why I got cancer or why this happened? And we do know that there's a genetic change that starts the process to transform a normal cell into a cancer cell. So there's a genetic change that occurs, and then that cell begins to divide and divide and divide, and eventually create a tumor. And it's uncontrolled. Normal cells will stop growing and stop dividing when they bump up against another cell. These cells just continue to grow and divide because of that genetic change that occurs early on. And this just shows you the hallmarks of cancer, everything from the cells not dying when they're supposed to avoiding immune destruction and not allowing the immune system to clear it, even though it's an abnormal cell, to inducing angiogenesis, which is blood vessel ingrowth, creating instability and mutation. So all of these hallmarks of cancer we know exist. And then we also know what genes are mutated to lead to those hallmarks. And that's what you see all around here in the blue boxes, are genes that we know in cancers are mutated and thus lead to this abnormal cell that ultimately becomes a tumor and a cancer. Now, what we have done at AHN is developed a genome center, which analyzes all of the mutations that exist within the tumors. And Dr. Lafamboise, who you see here, is running this genome center. And so what he does is takes your tumor sample and analyzes for over 500 known genes. It's the largest panel really in existence today, looking at all the known genes that might be mutated in your cancer. And these are, what you see here are just all of the different genes based on the type of cancer that he measures, to then tell us, could there be a therapeutic associated with that mutation? Or can that mutation help us define how your cancer is going to behave? And this process we're continuing to learn. But what's nice is that we can do this internally in our own laboratory and define these mutations and then manage patients accordingly. And this shows you how those mutations lead to cancer therapeutics. And the first one was 2001, when it was recognized that this BCR-ABL gene was mutated, and they developed a targeted drug, imatinib, that would target that mutation. And it was a game changer for these types of cancers, very rare cancers that had this mutation. But those cancers responded to that treatment, and patients could stay on that treatment for years and continue to respond to that treatment. It was a game changer overnight for those types of cancers. But what you can see is all of the different drugs that have been approved by the FDA to treat as a targeted agent to treat certain mutations that exist in cancer. So this is where we are today, with all of these drugs now at our fingertips to use for your cancer. And we have at AHN a molecular tumor board every week that discusses the mutational profile of patients' cancers, and then helps the clinicians look at what opportunities there are, both in terms of approved drugs as well as clinical trials that may be available. So this, is just why patients are doing so much better today than they used to, because we have more options than we used to, and targeted for mutations that we could measure internally. And I wanted to just talk about another program on the surgical oncology side, which is our peritoneal metastases program. And this is a unique program where we take patients that have small cancers that have spread throughout their abdominal cavity, and we take those patients to surgery and remove every one of these tumors, sometimes thousands of tumors that we surgically excise with a procedure that could last 12, 14, or 14 hours, as you might imagine, to get all these cancers out. And then we bathe the insides in chemotherapy and hyperthermia to try to kill any of the cancer cells that we can't see that might lead to a recurrence. So this is an example of kind of going, very aggressive, combining surgery and chemotherapy together as a treatment for this cancer that spread into the abdominal cavity. It hasn't spread to the rest of the body and is just focused on the abdominal cavity, and trying to manage this in an aggressive way. And this program is one that has a very good reputation, and patients do travel from all over the world to get these complex surgeries here, because we have the experience to do that, and we have good outcomes with that. And I wanted to just talk about one of the clinical trials associated with doing these operations, and again, just kind of showing you an advance and where we're getting. We have a company that has developed a nanoparticle that targets these cancers all over the body. And it targets it with a fluorescent molecule that, when the nanoparticle, which we give intravenously, it circulates throughout the body, when it finds a tumor, the nanoparticle breaks down and the fluorescent molecule is released. And so when we're looking at a cancer in the abdominal cavity, and this shows, you can almost not see that there's even a cancer there. But when we shine a UV light on that same piece of bowel, you see a very bright tumor. So we're lighting up the cancer to help us in terms of being able to excise every single nodule of cancer that patient has in the abdominal cavity. Easy to miss something like this, especially when you're talking about 100 other nodules like it. Very difficult to miss something like this. And you can see other examples of that. It's a small nodule here, lighting up very brightly. Here looks like normal tissue, nothing really jumping out at you, and then you've got a tumor here that lights up. And so we did show with that study that the tumors lit up and that it did help us in removing disease that we otherwise would not have seen. And then you might ask, well, if it does that and lights up cancer, why not include a therapeutic molecule in that nanoparticle so that you could target a therapeutic molecule to the cancer? And that's exactly what the company has decided. It is so good at targeting cancer that they've now developed a nanoparticle that has a therapeutic molecule in it, and we're going to run a clinical trial using that agent. It's not open yet, but will hopefully be open within the next few months, that will use this targeting nanoparticle to target an immune therapy molecule to the cancer. And then just quickly, I wanted to talk about using viruses to kill cancer. This is something that Dr. Edington has been a pioneer with, and so he may go into this a little bit more as part of our skin cancer center. But I've been interested for a long time in using live viruses to kill cancer cells. And this is a pox virus, similar to smallpox, a very aggressive virus that with a very small inoculum in the body can take over the body. We train this virus by using mutations so that it only infects and divides and replicates in cancer cells. And this is just the schematic of the virus here, infecting a cancer cell, and then the virus, as part of its normal life cycle, releases out of that cell thousands of viral particles that then go on to infect other cancer cells. But normal cells are not infected and therefore survive the treatment. So this is a way that you can use a virus, which we know can cause harm, mutate it so it only causes that harm to the cancer cells and not to normal cells. And this is a technology that has evolved really over the last 30 years. We've known of the potential for this to be impactful, but it's taken a long time for us to really figure out how best to do this. And this is something that we've been working on, which is not only relying on the virus itself to kill the cells, but also to express genes within that virus, because I can manipulate that virus and have it express genes and proteins that can then induce an immune attack. So what we've done is, in addition to make it so that that virus only kills cancer cells, is have it express an immune stimulating gene. So now the virus goes in, infects the cell, kills the cell, releases a lot of proteins, but then attracts the immune system in to then trick the immune system into killing more cancer cells. And so this is what we're working on. And I'm going to go through this very quickly, but I think it's mostly just to show you kind of how far we can get with all of this within our capabilities at AHN and within this new laboratory that we're developing and our clinical trial programs in cell therapy. So this is a project in conjunction with a company, Turnstone, where we're going to inject this pox virus into a tumor. And within that tumor, that virus will replicate, as we saw, divide, kill the cells, release a lot of proteins, antigens that excite the immune system. And then it's going to express this interleukin-2, this very hot inflammatory molecule, and then attract all of these immune cells into that tumor. And we expect those immune cells that are attracted, some are going to be specific to the virus and some are going to be specific to the tumor. And then we're going to harvest that tumor, which means we're going to excise that tumor surgically. And then we're going to take those immune cells that have now been attracted into that tumor, and we're going to then expand those immune cells. And in a very complex way, we're going to make sure that and select for those immune cells that will target the cancer. And then through equipment that we have and that others have, which includes the Prodigy machine that Dr. Lister was talking about, we can expand those cells into literally billions of cells, and then infuse those cells back into the patient. And those cells ideally will survive for even the rest of the patient's life. So these T cells can survive, and anytime a cancer cell shows up, they can expand internally, just like your body would fight off a virus and kill those cells. So that's where the excitement is for me, is that if you can trick the immune system into responding against the cancer, it's a lifelong or a potentially lifelong cure. And so this is very complex, but if it works, we'll figure out how to make it simpler. And anyway, this is the future. We're not there yet. We're just at the point of kind of working with the FDA to get the trial approved. But the hope and expectation is within the year, we'll have this up and running and start to see what kind of impact it can have. And I always warn patients that clinical trials are not magical. We hope they are, but in general, that we're going to learn a lot more about what our next step should be, and it won't be a magical cure. But it's nice to kind of have the vision of what we think will work. And just to end here, I just wanted to introduce you to some of our new recruits over the last couple of years. You met Dr. Lister, you're going to meet Dr. Edington, but we've have some wonderful new leadership recruits. Dr. Kupi leading our breast surgery service, recruited from Mass General in Boston. We have Nathan Bahari, who's been a national leader in GI oncology, helping us lead medical oncology. Dr. Berrywall and Dr. Champ leading our radiation oncology program, as well as our exercise oncology program. Dr. Champ has been in the news a lot lately with his program and what impact that's having on our cancer patients. And our most recent recruit, Dr. Lopez Chavez, who's running our precision medicine developmental therapeutics in our clinical phase 1 trial program. So we're excited about this. Obviously, a number of other individuals who have been here a long time and leading different aspects of our program, but these are just some of the new recruits I wanted to introduce you to. And then just to give you the footprint, we have 20 different sites across Western Pennsylvania. Pictures here. Many of these are brand new sites, very nice cancer centers throughout the region. Over 1,100 employees, 150 physicians, and a lot of capacity and capabilities throughout the region. So I will stop there and hand it over or back over to you, Tanya.
Thank you, Dr. Bartlett. That was very informative. Next up, we have Dr. Edington. With more than 30 years of experience, Dr. Howard Edington specializes in the surgical treatment of melanoma and cutaneous and soft tissue malignancies. He is the director of AHN's Cutaneous Oncology Program and the AHN Cancer Institute Skin Cancer Center. He is a pioneer at AHN in using oncolytic virus therapy to treat non-resectable melanomas. Dr. Edington completed his surgical residency at the University of Pittsburgh Medical School and continued his training at the National Cancer Institute in Bethesda, Maryland, completing his fellowship in surgical oncology. Dr. Edington is board certified in plastic and reconstructive surgery, as well as general surgery. He has authored or contributed to over 200 publications, and he has been awarded as one of Pittsburgh's best doctors for over 25 years. Welcome, Dr. Edington.
Great, thank you. It's a pleasure to be here, and it's very difficult to follow Dr. Bartlett. However, here I am. So I share the sentiments of Dr. Lister, and certainly the gratitude to all the folks that have made possible the opening of the Melanoma and Skin Cancer Center and Research Lab. This is a schematic of what it looks like, and you can see here that this is the lab, and over here we have the clinical center. And so Dr. Bartlett will remember from his time at the NCI that this was really the model in the surgery branch at the National Cancer Institute, where the lab was right next to the ward. And this was really a very exciting design because it allowed the researchers access to see patients, and patients actually to see that scientists were very interested in coming up with new treatments and new hope for them in their battle against cancer, which has been very nicely plotted out by Dr. Bartlett. This area here is the lab. This here is the Skin Cancer Center, or the Melanoma and Skin Cancer Center. We have designed it to be patient-centric and really hopefully emphasize collaborative and translational efforts. So I'm personally absolutely delighted to have the opportunity to work with Dr. Bartlett, Dr. Donnenberg, Dr. Lister, who are giants in the field, and I share Dr. Bartlett and Lister's anticipation that we really are on the cutting edge of new options for patients having cancer. On the right is Jessica Rogowitz, who founded the Pittsburgh Melanoma Foundation. And the center actually is open. The clinical facility is open. The lab will be opening shortly. This is the waiting room. The clinical facility is beautifully done and represents a lot of work by administration. Again, our gratitude to the foundation and for supporting this and everyone's vision for the future. A couple of things about skin cancer that a lot of people don't know. If you add up all of the cases of skin cancer per year, and this excludes melanoma actually, it exceeds all the other cancers put together. So it's a huge number of cases. It's a huge cost. Most of the non-melanoma skin cancers are not really counted aggressively simply because, for the most part, they're readily taken care of in the office. And there isn't a national registry for them, oddly enough. Melanoma, however, is a slightly different case. Melanoma, as most of you are aware, can be extremely aggressive. The key to melanoma is diagnosing it early, and that's part of the reason that foundations such as the Pittsburgh Melanoma Foundation are so valuable, because they increase awareness, forcing patients into screening and modifying environmental risk, namely excessive sun exposure, tanning bed, those sort of things. At the bottom, you see that the survival of patients with melanoma that's early is very good. It's a 99% 5-year survival for early detection, but that drops off as the disease progresses. So it's key to diagnosing this problem early. Up in the right-hand corner, you see the contributions of Honjo and Allison that they were appropriately, I believe, awarded the Nobel Prize for their contributions to immunotherapy as a new treatment, if you will. Not new, but one that has now come to the forefront. It's not new because both Dr. Bartlett and I were working on this at the NCI many years ago. Me more than him in terms of long time ago. But the immunotherapy has now come to the forefront as a very effective treatment modality, not just for melanoma, in which these drugs cut their teeth, but now for many other malignancies as well, including lung cancer and perhaps some forms of breast cancer as well. Dr. Bartlett shared some bad news in terms of cancer incidence with respect to the raising rates of pancreatic cancer. But one of the things here you see in the black is the increasing incidence of melanoma. And this is a paper that was put out in 2021 by JAMA, showing that by 2040, it is likely that, that melanoma will be the second most common cancer. So again, the need to diagnose early, treat early, and also the need for additional treatment options for patients in whom, as Dr. Bartlett said, the cat is out of the bag. That obviously that's a job for all of us, is to prevent that cat from getting out. The Skin Cancer Center that has just opened, what we want to do is offer services for patients that are at risk for skin cancer or who thought to have skin cancer. We're not out to replace dermatology as a core service, but we are wanting to work with our dermatologic colleagues in providing additional care and expertise potentially for patients either having skin cancer or at risk for skin cancer. Emphasizing the need for early diagnosis, we will and are offering imaging, skin cancer screening, evaluation and biopsy, and useful new technologies, which include DermTech, but may include devices such that Dr. Bartlett outlined with respect to imaging of cancers in situ. These are other services that we would want to and are currently providing that really would augment what's available in the community through our dermatologic colleagues. Again, we're not looking to replace them, but to work with them. Skin cancer screening is one service that I'll be talking about. Therapeutics, cell therapy that Dr. Lister outlined is extremely exciting, and I think is going to be very much a paradigm shift for us. We have several protocols up and running and have treated a number of patients. And this is an interesting sort of arrangement in the sense that the liquid tumor guys, meaning Dr. Lister and his team, are now working hand in hand with the solid tumor people like myself and Dr. Bartlett. So it's a new sort of partnership, and one that's very exciting to me. Systemic therapy options building on the immunotherapy advances that have been completed fairly recently remain very exciting. We're interested in sort of manning specialty clinics to provide care for patients that may not be able to get such attention perhaps in the community. And these would include high-risk patients, transplant patients, immunosuppressed patients, and patients having adverse events from immunotherapy. Melanoma statistics, the bulk of them are actually found early. And so you see here 78% of cases present and are managed at a localized state where the 5-year survival is actually very good. But when that starts breaking down and you have regional or nodal disease or distant disease, the cat is indeed out of the bag. And we just need to have better treatments for the patients in these groups. Things are getting better, but not fast enough. The old adage in terms of diagnosing melanoma early is simply a pattern recognition game. The ABCs are known to most of us: asymmetry, border irregularity, color variegations, diameter, and then evolution, which I think now is becoming a much more important marker suggesting the potential for malignancy. Beth, my manager, I promised not to show these pictures again because they're so old, but this is a young patient who's cheerleader for the Buffalo Bills, or was. And can anyone see where her problem is? Obviously, you can't speak to me, so I'll tell you the answer. But it's right there. And the vexing problem for many of us who take care of patients with melanoma is that 95% of them occur on the skin and are therefore visible. And so the key is really understanding which ones to pursue, which ones to biopsy. And it's heartbreaking when a young person such as this dies unnecessarily. So we have just obtained this device, which I think will transform skin cancer screening. The device is the Vectra 360 whole body imager. It's billed as being operational at West Penn early October. Thanks to the hard work of Loretta Hanwell and others, it is actually functional right now. We've started using this, and I'll walk you through a little bit how it works, and you can see, I think, through the few slides that I may show, the potential utility of this device. It instantaneously photographs a patient's entire body, facilitates the effective surveillance of lesions, and as the images that I show you will, I think, underscore, it allows us to process patients fairly quickly. This whole body camera is augmented also by handheld dermatoscopes that interface with the whole body imager, and more importantly, actually allow the practitioner to compare the image with a set of known images or a learning set. And so this really is where the AI algorithm actually is working. The image will be compared with a variety of known images, and the output of the machine will tell you not what the lesion is, but what the lesion looks like. The device is huge, but the camera is an entire device that occupies essentially an entire exam room. So it's not small, it's a big machine. This is an example of one of the first patients that we imaged with a camera. He actually, and this is notable, I believe that he drove 4 hours to get this done. He does have a history of melanoma. You can see here that this is the posterior view of him. These are his moles. You see here that the camera has identified just shy of 2,000 moles. I have trouble keeping track of my socks, but I know that I can't keep track of 2,000 moles on a patient. The beauty here is that each of these moles will be compared to known entities in the learning set of the AI, if you will, algorithm, and they'll be assigned a severity score. So what happens then is the patient has a catalog of all his or her moles on record, and it is possible to identify within their the catalog that they've obtained at time 0 moles that might be concerning and might be followed up with a biopsy. However, more importantly, when this patient gets a repeat exam in a year, the machine will actually compare each mole in a longitudinal fashion. So it will be able to track changes in each individual mole. That's 2,000 moles, and they're able to do that very rapidly. So this really extends for the high-risk patient the options for follow-up. This is the machine gives you the opportunity to sort out all the separate images, look at them more closely, etc., and catalog them in terms of follow-up. The machine will also generate a report for the patient. And this is a second patient that was imaged fairly recently and showing what I would consider a fairly innocuous lesion, but with a fairly high score in terms of severity, in terms of comparison with known images in the data set of the machine and its algorithm, and recommend that this one be biopsied. This is a separate patient. This isn't the same patient, but this then picks up a lesion which I think looks a lot more worrisome, but under dermoscopy, it actually is one that can be watched carefully. You can see here that this one has a DEXI score, which is a computer-generated score based on the appearance of the lesion and its comparison with known entities in the learning set. The 7 is a much higher than 0.3. Obviously, the individual practitioner has to take the results and decide what to do. This device uses white light and polarized light. This is an example of an image obtained with cross-polarization. And it shows that the risk assessment by the machine is fairly low. At the end, the machine is able to generate a report for the patients and select for recommendation the possibility for recommending excisional biopsy for certain lesions, as well as routine follow-up for the others. So I think that this is going to be a welcome advance to what we can do in terms of screening. The technology also will actually impact very nicely our relationship in terms of opening up an imaging institute here to build on some of the research endeavors that we've started in conjunction with Carnegie Mellon, looking not just at a conventional imaging, but looking at different sensors, different ways of looking at images that are obtained, and hoping to actually come up with better hardware that can be used to screen appropriately. The holy grail, if you will, is to obtain a combination of hardware and software that would facilitate an optical biopsy. So the new screening modality that is now up and running is both very exciting. I think it offers a number of advantages in the sense that it is an objective evaluation. I don't think it's going to replace the trained eyes of a dermatologist, but it is nonetheless objective. I think as the software improves and the AI algorithms improve, it will become more and more reliable. It allows patients to have a report. Many of these patients are high risk in the sense that they've had multiple melanomas, they're terrified, and they really are looking for as much attention as they can get. As I pointed out already, we have patients that are willing to drive 4 hours to get this. When we started to go through the process of acquiring the machine, there were 6 in the country. Now there are 15, and I think we have the only one within about 4 hours driving distance. So it's providing a service to the community that is welcomed. The private dermatologists are actually quite excited and don't see this as a threat, and it isn't. The longitudinal use of this imaging is going to be very powerful for us to look at the lesions that are changing. I think the changing lesions are the ones that allow you to diagnose a problem at a very early stage and put that patient in the 99% 5-year survival category. The deployment of the handheld dermatoscopes is allowing us to sort of migrate this technology and the advantages of this technology out into some of the PCP offices where PCPs are now are being called into doing skin checks as part of their routine. And this is, I think, going to be a very welcome augmentation to their practice. Right now, the exams are not covered by insurance, so they're covered out of, so it's an out-of-pocket charge for the patients. The patients that we've pooled most recently are very happy and willing to pay the out-of-pocket price. Going forward, I think that it probably may be covered by insurance, probably not in the next year or so. And I think as deductibles get bigger and bigger, the cost of this, something like this, is going to become something that is palatable to many patients. Limitations are, I think the current software has some limitations, but I think with the progress forward, the software is just going to get better and better and better. And this should be one of the areas of AI, if you will, that should be getting better almost exponentially each year. The software is obviously contextual, meaning that in both those images I showed you, the nipples show up as on the patients show up as lesions. Obviously, you have to be able to say, okay, wait a moment, that's not a lesion; it's something that's supposed to be there. So you know, it's not infallible. For some of the patients that are terrified that they have melanoma, this is a new test out that we will be incorporating in the center, where the specimen or mole is sampled with a piece of sticky adhesive tape. The tape is sent off to the company. They do a genetic analysis of the cells that are on the tape, and based on a three-level test, the ones that are negative for all three, 99% chance it's not a melanoma. You know, you don't know what it is, but at least that gives a lot of patients, and particularly families that have young children in whom that you really don't want to do a biopsy unless it's absolutely necessary, some additional peace of mind. This is the phone number where people can contact us to make an appointment for these services. I'm probably going to stop here. The rest of my slides are strictly research slides having to do with imaging efforts that we're trying to get up and running to look at new hardware, new sensors to improve on currently available technology for imaging, since that, as I said earlier, 95% of these are right on the skin where you can see them. So thank you all for your attention, and thanks again to the foundation and administration for making this all happen. I think it's a very exciting time for all of us in cancer care.
Thank you, Dr. Edington, for sharing this really innovative type of equipment that we have available at AHN. There are a number of questions in the chat related to accessibility of this equipment, and I would encourage everyone to call our Hope line at 412-578-6473 to get an appointment scheduled, or to, if you have additional questions related to the machine, we can certainly get those answers for you. I know we're about out of time, so I think we're going to move forward to just close the presentation for this evening.
Sure. Thank you, Crystal. We would like to thank all of you for attending our Ahead of Cancer lecture this evening. Please continue to join us at our monthly Ahead of Cancer lecture series as we focus on cancer screening, early detection, treatment, and survivorship. As a reminder, tonight's lecture was recorded. If you're interested in rewatching tonight's lecture, check back on the AHN YouTube channel, www.youtube.com/Allegheny Health Network for the full recording in about a week. This video, as well as all other past lectures, will be posted under the Ahead of Cancer playlist. If you would like to schedule an appointment or have questions regarding a potential cancer concern, please call the Hope line at 412-578-6473 to schedule an appointment. You may also call our 24-hour Nurse for You line at 412-687-4968. Thank you again, Dr. Bartlett, Dr. Lister, and Dr. Edington for the great presentations, and thanks to all who attended the lecture this evening.